All right. Good morning, everyone. My name is Carissa Chu. I am a urology resident at UCSF. It is my pleasure to introduce Dr. Ryan Smith from the University of Virginia. He's going to be talking to us about the evaluation and management of male infertility. So without further ado, Dr. Smith.
Great. Thanks so much, Carissa. And I just want to say it's a privilege to be with all of you today. And thank you to you individually and your whole departments as you care for our country during this time. And as Carissa said, we're going to dive into the evaluation and then specifically the non-surgical management of male infertility. Dr. Sarah Krostek, who used to be with us at UVA, is going to be talking about surgical management, I think, coming up. I don't have any relevant disclosures for today's talk, and we're going to start out with just a brief reproductive physiology review, and then into the clinical evaluation, and then, as I mentioned, non-surgical treatment for male infertility, and we'll wrap up around 45 minutes. And I also have Dr. Devang Sharma, who's our infertility fellow, who's joined in with us today. So just as kind of a background information, this is just a quote that came out a few years ago, and so there's still a lot that we don't understand about reproductive physiology, and so take some of this with a grain of salt as their knowledge continues to evolve. But beginning with the embryology, so the SRY gene is on the short arm of the Y chromosome, and it's influenced by other genes, as noted here. Once sex determination occurs following the SRY, Leydig cells begin to produce testosterone, which leads to development of the internal genitalia. You have the conversion to DHT, which results in development of the external genitalia. And then conversely, the Sertoli cells begin producing MIS, Mullerian inhibiting substance, which prevents the Mullerian duct from developing into the uterus and fallopian tubes. It's important to note there are 3 surges in testosterone. The first begins neonatally, so around 12 to 18 weeks, then at about 2 months and puberty. And so a little bit of anatomy and physiology review for each of you. And most of this stuff is taken from Campbell's, but distilled down for our information today. So normal testicular volumes, approximately 15 to 20 cc's, or about 4.5 to 5 centimeters in length, or the long axis, which has implications which we'll discuss later. The vascular supply to the testis involves the testicular artery, the basal, and the cremasteric. And that redundancy is important anytime we're doing surgery on the spermatic cord. The Leydig cells, as we just mentioned, result in testosterone production, and Sertoli cells are the nurse cells for sperm production. They also contribute to the tight junctions, which result in the blood-testis barrier. And our understanding of that is that it's likely immunologically isolating and protecting the developing male gametes. The epididymis itself is comprised of 3 regions. So you have the caput, corpus, and the caudal portion. Sperm, as they transit the epididymis, are really developing in terms of maturity and acquiring both motility and then ability to bind to and penetrate the egg zona pellucida. That transit time is variable, and it's on the order of 2 to 12 days. So the image here is of the vas deferens, which has a very high muscle to lumen ratio. So anyone who's been a part of doing vasectomies or vasectomy reversals, you're well aware of this. It's derived from the Mesonephric or Wolffian duct, which additional structures are also derived from, including the seminal vesicles, the ejaculatory duct, and the epididymis, aside from the caput. And then, of course, the seminal vesicles, also important in terms of seminal fluid production. And when obstructed, they will notably be dilated on transrectal ultrasound. We specifically state that over 1.5 centimeters is likely pathologic or indicative of obstruction. And we'll talk more in detail about that later. And then from there, you have the ejaculatory duct, which empties into the prostatic urethra at the verumontanum, and we see on cystoscopy. So when we talk about mesonephric duct abnormalities or anatomic abnormalities as they pertain to male infertility, You can have unilateral absence of the vas deferens, which is associated with renal agenesis. You can have congenital absence of the vas deferens, wherein you'll also typically see agenesis or severe atrophy of the seminal vesicles if you're doing a transrectal ultrasound. And then, of course, prostatic cysts or utricles, they can result in obstruction or both complete or partial of the ejaculatory duct. So briefly, touching base on spermatogenesis, in general, 42 to 76 days, and we do know that there's some individual variation. You'll see that often when we talk to patients about improvements after procedures that it can take 3 months or longer, and that's primarily based off that length of a sperm cycle. It's occurring in stages, cycles, and waves to ensure essentially constant sperm production. And there are genes both on the X and the Y chromosome that govern spermatogenesis, and we'll talk about the genetic evaluation a little bit later on. And we know that with advanced paternal age, and there's some debate about when that occurs, but somewhere around age 40, based on some papers, some would argue 50, there are increases in sperm structural abnormalities, autosomal dominant mutations, and then epigenetic changes that can lead to disease in offspring. Some of those structural abnormalities I was referring to, so you can have non-specific flagellar abnormalities, which will result in changes in motility. That may be resultant from a varicocele or elevated levels of reactive oxygen species, or perhaps in patients who've had other chemotherapy or gonadotoxin exposure. And then you can have dysplasia of the fibrous sheath, where you have zero motility, and that can be associated with respiratory disease, dextrocardia, and ciliary dyskinesia. In terms of the semen, so focusing just on the seminal vesicle contributions, there's a number of different things that occur. So those secretions can promote motility further than that which was gained in the epididymis transit. It stabilizes the sperm DNA packaging, suppresses the immune activity of the female reproductive tract. It's rich in antioxidants and fructose, which protect and ensure the health and quality of the sperm. So if you have an acidic ejaculate, and we'll talk about this later in the evaluation, that can suggest blockage or absence of the seminal vesicles. So stepping away from anatomy, we're going to talk more a little bit in the physiology and endocrine perspective. So when we talk about the male hormonal evaluation, we start with the hypothalamus, which results in GnRH secretion, which is seasonal, circadian, and very pulsatile. It stimulates LH and FSH production, which is occurring at the anterior pituitary. And then abnormalities such as Kallmann syndrome, which is where the GnRH neurons fail to migrate, you get hypogonadotropic hypogonadism. And we'll talk about the management of that in a little bit here. And then, of course, the pituitary is highly involved in the reproductive axis. LH stimulating Leydig cells to produce testosterone, FSH impacting the Sertoli cells and resulting in sperm production. The role of prolactin is a little bit less clear, but it may increase the concentration of LH receptors, resulting in higher levels of intratesticular testosterone. And we'll talk about what elevated prolactin levels can do to male infertility in just a bit. And then, of course, that feedback loop is highly important. So testosterone provides negative feedback at the hypothalamus and the anterior pituitary, but more so at the hypothalamus. Testosterone gets converted to DHT or dihydrotestosterone via 5-alpha reductase. And testosterone gets converted to estrogen via aromatase, in particular in fatty tissue, which has implications for men with obesity. And then you have actin and inhibin, which affect FSH secretion. And notably, FSH secretion is relatively independent of GnRH stimulation. So testosterone itself, as you all know, exists in multiple forms. So it can be tightly bound to sex hormone binding globulin or loosely bound to other proteins such as albumin. And then the free portion, or around 2% or so, is around to do the work. In general, we expect peaks in testosterone in the morning with a subsequent trough in the afternoon for men. And per the AUA guidelines, which is the only guideline which really has drawn a line in the sand, a testosterone below 300 nanograms per deciliter is considered low. Importantly for us to know is that serum estimates of testosterone obviously don't reflect the intratesticular levels, and those are typically much higher. And sex hormone binding globulin can impact what we see in terms of low testosterone. So disease states such as obesity, hypothyroidism, and diabetes can lower SHBG. And then conditions such as aging, cirrhosis, and HIV will actually raise sex hormone binding globulin. So if you're checking free testosterone, that will be reflected in your results if patients do have some of those diseases. So that's all the physiology background we'll do. Many of you may have breathed a sigh of relief now. We're going to go into the clinical evaluation of male infertility. So importantly, just as background, there's been a significant rise in the use of assisted reproductive technologies, both within the United States, wherein it's just under 10%, but you'll see other countries are even upwards of 10%. It's estimated, and this is almost a decade old now, but just under 50 million couples worldwide struggle with infertility. And the United Nations predicts a global fertility decline over the coming decades. And US birth rates, as I mentioned, have been going down. 2018 was the last reported year, and that was the fourth year of decline since 2014. We're at our current lowest levels in 3 decades and have fallen below the fertility rate of what's needed for the population to replace itself. And there are likely multifactorial reasons for that. But in general, if you look just at the United States, it's around 1 in 8 couples who struggle with infertility, just over 1 million women per year who make a new office visit for an evaluation, but only about 20% of the male partners actually undergo an evaluation. So we're missing a lot of men in terms of their evaluation, and that's important because male infertility is a reflection really of overall health and a measure of overall health. And we know that about 50% of the time when a couple struggles with infertility, the man's involved. Around 30% of the time, it's the man alone. And here are just some common items that will be detected at the time of an infertility visit, and some of the limitations of us as male reproductive physicians in terms of when we are seeing patients. So one is you'll see the large number of idiopathic cases, and some have suggested this is upwards of 40%. Of course, varicocele being the other most common diagnosis. We know that a semen analysis is a limited measure in terms of being able to assess a man's fertility. And many urologists don't have a fertility specialist at their program or receive little training in it. We've often taken a backseat to perceptions that IVF is a safe cure-all for male fertility. And many of our reproductive endocrinology colleagues are really the gatekeepers in terms of referrals or getting patients to see us versus just pursuing assisted reproduction. So the history is really crucial when we talk about male infertility. And so some of the items you want to think about in terms of when to actually undergo a fertility evaluation is that one is obviously if there are any sort of risk factors, the patient has a known history of a varicocele. Guidelines suggest if the female partner is over 35 years old, that a couple should have an earlier evaluation. And we know in general, if couples have tried for approximately 1 year, that if they have not conceived, that would be a good time for an evaluation as well. 92% will conceive after about 2 years. But notably, only a minority of couples who haven't conceived by 6 months will do so in the remaining 6. And so it's reasonable to initiate an evaluation even as early as 6 months. So some of the items you'll want to ask about in your history are, of course, include any prior conceptions, contraception use. Again, partner age is very important, and the female history in terms of any female factor infertility concerns, the frequency and timing of intercourse, any underlying family history of infertility, sexual function, obviously very important. So asking about a man's libido, erectile function, any difficulty with ejaculation, whether or not the couple is using lubricants, which may or may not be spermicidal. And then you want to ask about past medical history. So that may include prior chemotherapy exposures or radiation exposures, of course, reproductive tract infections, testicular torsion, trauma, and then undescended testicles, a hernia that might result in obstruction, obviously prior vasectomy or retroperitoneal lymph node dissection that might result in retrograde ejaculation. And then a number of different medications can impact fertility. And unfortunately, our understanding of this is somewhat limited as many drugs are not tested in terms of the impact they may have on sperm. And if they are tested, oftentimes it's in an animal model. We, of course, know that testosterone replacement therapy negatively impacts sperm production and can result in azoospermia over time. Opioids can affect the hypothalamic pituitary gonadal axis. A number of antibiotics can have negative implications for sperm production or quality, and immunosuppressants additionally. It's important to ask about social history. So smoking, marijuana use, and heavy alcohol use, in particular binging, and illicit drug use can all have implications for fertility. And then also important to ask about environmental or occupational exposures. So people may have pesticide or herbicide exposures, or known exposures to other endocrine disrupting compounds or radiation, and of course thermal injuries such as things like hot tub use, and then laptops and cell phones for EMF radiation have been shown to negatively impact sperm production as well. So key components of the physical exam now, moving on from your history. So BMI is important for its implications. Obesity negatively impacts both from a hormonal perspective, but also a number of different sperm parameters. So habitus, important to note. And we'll talk just briefly later that many men with Klinefelter syndrome don't exhibit gynecomastia, tall stature, or those textbook phenotypic definitions. You want to note secondary sex characteristics. During your scrotal evaluation, evaluate testicular size, consistency, and then symmetry between the testes. For instance, a patient with varicocele, you may see size discrepancy between the right and the left testis. When you're examining the epididymis, you want to note, does it appear to be engorged, which might suggest obstruction. For a good baseline evaluation of this, if you're examining patients who've had a vasectomy, generally the epididymis is more prominent. And then of course the spermatic cord, you're wanting to evaluate the presence of a varicocele, which we'll dive into a little more detail later, and establish whether or not the vas deferens are present on both sides. Examining the penis, you might look for hypospadias or Peyronie's plaques. The prostate exam is of relatively limited utility. In general, when we talk about it, we're talking about whether or not you can palpate the seminal vesicles or a prostatic cyst, although those are both very challenging and better delineated with imaging. This standard testing, so the semen analysis, which I mentioned earlier, is the cornerstone of the male fertility evaluation, but it's problematic. I've listed the kind of normal reference ranges here for you, and these are taken from the World Health Organization, specifically in 2010, and they are really just the 5th percentile values from population-based studies. The recommendation is for a semen analysis to be obtained after at least 1 to 2 days of abstinence. We know that there's a large amount of variation within individuals in terms of the semen analysis, which is why we generally recommend 2 for comparison purposes. And in general, you want to separate those by 2 to 3 weeks if possible. And importantly for you to understand, obviously a semen analysis does not define fertile or infertile. So you can have men who fall below some of these reference values that will ultimately conceive if you follow them over time. So we'll go through and systematically talk about when semen parameters are abnormal and what do you do about it. So when we talk about volume, in general, the reference range is 1 to 1.5 cc's. So a low volume ejaculate would be hypospermia, absent ejaculate, aspermia. Can result from obstruction, so ejaculatory duct obstruction, which we mentioned earlier. You can have hypoplasia of the prostate or seminal vesicles. The seminal vesicles can be atrophic or in the setting of CVAVD as well. So bilateral absence of the vas deferens. Or you can have ejaculatory dysfunction. So patient who's had a retroperitoneal lymph node dissection, or a patient with long-standing uncontrolled diabetes, prior neurologic injury, or some drugs, as you all know. Some of our BPH medications can do it. So if you identify low ejaculate volume on a semen analysis, part of that evaluation, so an endocrine evaluation is important, so you can see low ejaculate volume in the setting of hypogonadism. From there, you would do a post-ejaculatory urinalysis, and this is generally done by having the patient void to empty their bladder, then collect the semen sample, and then followed by another urine sample. So you want to have very little urine to look through when you're doing that urinalysis to look for sperm. And there are varying definitions of retrograde ejaculation, but essentially a good standard is if the sperm in the urine nears or exceeds that in the antegrade specimen. That would be diagnostic. If your post-ejaculatory urinalysis was negative and you've ruled that out, then you continue to be concerned for obstruction, and a transrectal ultrasound is valuable in that setting, and we'll talk a little bit more about that coming up. So moving on to the next parameter, so density or concentration. So that fifth percentile is 15 million per milliliter. We deem when sperm concentration falls below this, that's oligospermia, so a low sperm count. And that's where two of our other indications for further testing come up. So one is if it falls below 5 million per milliliter, that's an indication for genetic testing, specifically a karyotype and a Y chromosome microdeletion. If we see the sperm density fall below 10 million per milliliter, that would be an indication to further pursue an endocrine evaluation for that patient. And if, of course, azoospermia, so no sperm in the ejaculate, that's going to prompt both an endocrine evaluation and a genetic evaluation. And it's important to remember this is defined after a semen sample is centrifuged down and no sperm are still seen. So if you just do a standard semen analysis and it's not centrifuged, you can miss even very low numbers of sperm, which if identified could be used for IVF, and the patient would not need a surgical procedure. And this is just taken from Campbell's. We'll talk a little bit more about this, but this is an algorithm developed by Craig Niederberger, which just shows in the setting of azoospermia, how do we evaluate this? So once you've established that both vasa are present, if the ejaculate volume's normal, then you can look at total long axis of the testis and the FSH, and that can help guide you in terms of predicting, does this patient have an obstructive cause to azoospermia or a non-obstructive cause? We talked a little bit more about, we talked just moments ago about ejaculatory issues. So moving on to motility. So in terms of motility concerns, we term this asthenospermia. If motility is at 0%, which we talked about a little bit earlier, you can perform vitality testing of sperm, and that's to assess whether the sperm are indeed just dead, or if they have abnormalities involving the tail or the fibrous sheath, as we talked about previously. Not all labs routinely do this, but important for you to know that it is available. And in general, if the motility is less than 10%, as well as vitality, one of the things you may look for is something like Cartaginer syndrome or primary ciliary dyskinesia. These are highly uncommon. To identify it, really, you would need to do electron microscopy to look for ultrastructural defects in terms of within the sperm level. Obviously, you can evaluate for these syndromes via evaluating other systems, but if we're just talking about from the reproductive side, this is very uncommon again. And morphology. So arguably the most controversial and potentially least useful parameter on a semen analysis. So when morphology is low, and you'll see the cutoff is 4%, and that's based off strict morphology assessments. That changed back in 2010, but it's just what it sounds like, which is very stringent criteria for what constitutes a normal shaped sperm. The clinical predictive value of morphology is very controversial. Men who just have an abnormal morphology assessment generally are found to have adequate reproductive potential. And morphology, importantly, doesn't appear to predict natural conception, IUI, or IVF outcomes. So it's important. You see a patient with just abnormal sperm shape. It may not be the end-all be-all. Severe cases are where the acrosome fails to form, so globosospermia. There's a picture there for you. The treatment in that setting is IVF ICSI, and again, very uncommon finding. So leukocytospermia. So this is another relatively controversial area in terms of talking about abnormal semen analyses. We define this as when there's over 1 million white blood cells per milliliter in a semen sample. And this is assessed generally with staining. So if you're just doing light microscopy or phase microscopy and not staining, you can get faked out by immature germ cells, which are going to be present, as they can look very much the same as white blood cells. So you need to have a staining assessment of this. We know that semen cultures are really not helpful. There are a number of commensal organisms. Of course, semen samples are generally collected via masturbation. So in general, there's skin flora present. If a patient doesn't have symptoms, it's unlikely to represent an infection. And we know that there are supposed to be white cells in the semen. To some degree, it's physiologic and even beneficial to sperm development. The reason why it's postulated to be detrimental in some cases is that it can increase reactive oxygen species, which has a number of negative downstream effects on sperm quality and development. The treatment, again, is not standardized, a little bit all over the map. So some people have traditionally used anti-inflammatories. There was a study that came out not too long ago that argued that even ibuprofen itself may have short-term impacts on testicular physiology. Parviz Kavusi did a nice follow-up study that showed no negative impacts in terms of sperm quality after NSAID use. But again, there's no standard of care, not great evidence that it's helpful in terms of aiding in conception. Traditionally, a lot of people have thrown antibiotics at patients with leukocytospermia. Really mixed evidence in terms of whether it has any sort of benefit. And as we mentioned before, many antibiotics can actually have negative impacts on sperm. Supplements we'll talk about later. Majority of the time, I would say at present, people will just observe leukocytospermia, especially low levels of it. And again, there's controversy about whether or not to treat a patient who demonstrates leukocytospermia prior to assisted reproductive techniques in terms of whether that actually ultimately impacts outcomes. So there are a number of different adjunct tests, many of which are continuing to evolve. So anti-sperm antibody is a little bit older test, which is rarely done today, but at present, the time indications maybe to do this would be if you see low motility and a high amount of agglutination of sperm in a sample. This may be a patient who's had a reproductive tract surgery or trauma. Again, rarely done, at least not routinely. There's a lot of controversy surrounding the utility of DNA fragmentation testing. So this essentially pertains to the packaging of the DNA within the sperm and whether it's really tightly bound or loosely bound, which may impact sperm function, fertilization, implantation, pregnancy. There are multiple different assays available for this, a lot of different reference ranges for this. So there are some indications where we might pursue DNA fragmentation testing, but again, this isn't a routine test, just important for you to know it exists. Fish testing, so we can assess for aneuploidy in sperm. Indications where we might pursue this are a patient with recurrent pregnancy loss, or recurrent implantation failure, recurrent IVF failure. The unfortunate thing is you can test one sample and we know that the patient provides another sample. Down the road, they may be completely different. And once you've tested the sperm, you can't use them for IVF, so you can't use it to select for good sperm. And then reactive oxygen species. So we mentioned earlier that excess leukocytes, sometimes varicocele, things like that can elevate reactive oxygen species, which may damage sperm quality. Again, this isn't necessarily a standard of care, but just important for you to know it exists. So transitioning away from the semen analysis, we'll talk a little bit about the endocrine evaluation. So So we mentioned a few indications to pursue this in patients, and there are some settings and some studies that argue we should be doing it in all patients. But specific indications would be abnormal semen parameters. So we talked about sperm concentration being one of those, or low ejaculate volume. Of course, if a patient reports to you that they've noticed diminished libido or having difficulty with sexual function, that may prompt you to test this. And then, or if they have clinical findings that suggest this would be warranted. And in general, that means getting a testosterone and an FSH. Campbell's and some others, as I mentioned, have argued that maybe we should be doing it more widespread and perhaps expanding the regimen to include an LH and an estradiol. Why they argue that is that even a large portion of men, or even a third of them who have a normal sperm concentration, may have an endocrinopathy. It's important to get a morning testosterone level per guidelines, but also in general, these are young men, and we know that those fluctuations in terms of morning to afternoon are all more pronounced in that setting. And we talked about that algorithm that I mentioned Dr. Niederberger had developed when looking at FSH and testicular long axis and how that can help you in terms of a patient with azoospermia. But it also helps you to see if a patient has a really elevated FSH, this may indicate testicular failure. Estradiol, arguably important in looking at the testosterone to estrogen ratio, because if some studies have suggested if this is below 10:1, that may indicate reproductive dysfunction. And prolactin, which we touched on earlier, we know that elevated levels, such as with a prolactinoma, this will result in abnormalities in the HPG axis, may need to prompt a pituitary MRI. So just for your own reference, so I touched just briefly there on testicular failure. In that setting, that one example may be Klinefelter syndrome. So you have a low testosterone, elevated FSH and LH, hypogonadic hypogonadism, which was much earlier in our talk. So Kallman syndrome, those patients have low LH and FSH and a low testosterone. If you have elevated prolactin, generally you see suppression of testosterone, FSH, and LH in that setting. And then there are a number of androgen insensitivity syndromes where testosterone may actually be high, LH is high, and FSH is variable. So moving on to genetics, again, our promptings to pursue this would include a patient who has non-obstructive azoospermia, so no sperm in the ejaculate, or a very low count, so less than 5 million per milliliter. And again, the two mainstays are a karyotype and a Y chromosome microdeletion. Other genetic testing that we use would be cystic fibrosis or CFTR testing in patients who have bilateral absence of the vas deferens, and important to test the female partner in that setting. There's likely a large number of idiopathic male infertility cases that have genetic underpinnings, and our understanding isn't quite there yet. But this can include other genetic changes such as chromosome translocations or rearrangements, or single gene losses or gains. In patients who are azoospermic or have really low counts, there's a clear role in doing this testing prior to assisted reproduction. And we know that men who have specifically low counts or non-obstructive azoospermia are at higher risk for malignancy. That can include testicular, prostate, and others. And overall, about 15% of the male genome is involved in reproduction, which is not a trivial amount. So talking about specific syndromes, so Klinefelters, important to remember they can have mosaicism. It's overall the most common genetic diagnosis in male infertility. And again, they're going to have hypergonadotropic, so elevated LH, FSH, hypogonadism. Many of them may have been initiated on testosterone during adolescence. It's somewhat controversial as to whether that has any negative reproductive implications for them down the road. Most will have azoospermia, but about 8% will have sperm in the ejaculate, so important to do a semen analysis. And as I mentioned previously, many of these patients don't have the classic phenotype that we hear about in textbooks, so keep that in mind. And testicular sperm extraction, retrieval rates are high in this patient population. So Y chromosome microdeletion testing. The fragility of the Y chromosome in particular is what increases the chance of there being microdeletions. And this is a PCR-based assay. It's denoted by AZF, comes from azoospermia factor. And the most common that you'll see are AZF A, B, and C microdeletions, and these show up on the in-service. And again, the indication is a patient who has no sperm in the ejaculate or a very low count, specifically less than 5 million per milliliter. You want to obtain these prior to doing a sperm extraction in a patient, and the reason for that is if they have an AZF-A or B microdeletion, they have a really low probability of sperm being identified, and we do not, in general, recommend pursuing microtestis or testicular sperm extraction in those patients. Conversely, patients with an AZF-C microdeletion have relatively high rates of success with a testicular sperm extraction. If you find a patient who does have a really low sperm count and you identify an AZF-C microdeletion, it's important to know that many of them can progress to actually having no sperm in the ejaculate, so you want to consider freezing sperm in that scenario. So vasal abnormalities, as you all know, you can have bilateral or unilateral absence of vas deferens, and in general, patients who have bilateral will, the majority of them will have at least one CFTR mutation. Those who have unilateral, still upwards of a third will have at least one CFTR mutation. These patients have low ejaculate volume and an acidic pH. This is a physical exam diagnosis. So in general, patients who had unilateral absence of the vas will have renal agenesis. So you want to do a renal ultrasound in those patients. If they have bilateral, as I mentioned, that's common for them to have a CFTR mutation. But even 11% of those will have a solitary kidney, so you could consider a renal ultrasound in that case. You want to assume if you identify bilateral absence of vas deferens, but your CFTR testing comes back negative, you still assume that the patient has a mutation. They can be variable based on ethnicity and geography, and it's important to always test the partner. These patients can undergo a sperm extraction IVF. The picture is showing you essentially a patient had an absent vas deferens. Oftentimes we'll see even a little cystic formation within the caput where the epididymis would be, whether that's resulting from the efferent duct or otherwise, where you can find sperm, or within the testis itself. So varicocele, touch on briefly, but so common. So 15% of all men actually have a varicocele, whereas 40% that we see for infertility or an abnormal semen analysis will have one. And 80% of men with secondary infertility will have varicocele. And we take that to mean that varicoceles may have more detriment over time. Secondary infertility being you had one child and you're having difficulty having a second. Again, this is another physical exam diagnosis. So a grade 1 is when it's palpable when the patient valsalvas. A grade 2, it means you can feel it even when they do not. And a grade 3 is visible. You can see varicoceles on ultrasound, and there are varying criteria for what constitutes a varicocele based on ultrasound. But in general, if you can't feel it, we don't deem it clinically significant and therefore would observe it. The indications for repair would be in an adolescent who had an abnormal semen analysis, if you're able to do one, or you see significant testicular asymmetry, or for pain. So imaging-wise, there are not a lot of absolute indications for imaging and infertility. So if you felt a mass, to evaluate for cancer, transrectal ultrasound. So again, if you see greater than 1.5 centimeters of dilation in the seminal vesicles, that would indicate ejaculatory duct obstruction. Vasography is not routinely performed anymore. We do a saline injection at the time of vasectomy reversal or additional passage of a suture to confirm patency, and that manual feedback is enough. MRI, highly uncommon, but you can evaluate the prostate and seminal vesicles. And we talked about renal ultrasound with unilateral absence of vas deferens. And people have argued for doing a renal or retroperitoneal ultrasound for patients who have a unilateral right varicocele. There is some debate about that, but in general, most people still do it. So there's a lot that's changed over the years in terms of the clinical evaluation for the infertile male, and we've talked about some of the newest testing and some of the adjunct testing. So we're going to just touch briefly on non-surgical management, again, leaving the surgical to Dr. Krostek coming up. So Kallman syndrome, which we talked about, treatment-wise, so those patients have low LH and FSH, and essentially what you're doing is replacing those hormones with HCG, which replaces LH and recombinant FSH. In Klinefelter syndrome, we talked about there being high success rates in terms of sperm extraction, and they often do have some testosterone exposure. However, this doesn't appear to have negative implications for sperm retrieval later in life. And patients with elevated prolactin, we talked about the indication for pituitary MRI when it's significantly elevated, and I've listed for you there where you have mild elevations where likely no further evaluation is needed. And those patients will ultimately either have dopamine agonist therapy or less commonly surgery. So non-testosterone-based management of hypogonadism and infertility, I'm just going to focus on the infertility parts. Dr. Brannigan may have touched on some of this, but so in general, when we talk about SERMs or selective estrogen receptor modulators, Clomid's the most common. It's been used off-label for low testosterone and male infertility for quite some time, and I've put the dosing there. And through its modulation of the estrogen receptor, blocking that negative feedback, you get a subsequent rise in LH and FSH, so that LH will stimulate testosterone production very reliably, and FSH goes up, and in some patients, you'll see a response in terms of sperm production, although not all. Dr. Krostek, who I mentioned through some work here, showed that Clomid's safe and effective in long-term treatment of low testosterone for men who wish to preserve fertility and a relatively low rate of side effects. It's been used in infertility, both, let's say most commonly in the setting where you have a patient who has hypogonadism plus infertility. Appears to be less effective in the setting of just empiric treatment to raise sperm production. Dr. Sharma, who I mentioned previously, has looked into this in terms of predictors of fertility response. And there are indications where you might want to employ this. And in patients who have a low count and maybe are not able to undergo assisted reproduction or want to try everything possible, that may be a setting. Again, predictors are relatively difficult to identify. There was a Cochrane review done in 2007 that showed Clomid does reliably improve on endocrine profiles, but still mixed evidence in terms of its efficacy to improve on fertility. Another class of medications are aromatase inhibitors. So these are blocking the conversion of testosterone to estrogen. And again, just dosing for your reference there, although it's a little bit, it's highly variable depending on practitioner. There may be some subsets of populations where this is useful. So we mentioned the importance of the testosterone to estrogen ratio and maximizing that. That may be a patient with obesity or Klinefelter syndrome where this drug may be useful. However, generally not good in the long term, as some of the side effects include bone density loss and LFT elevation are problematic. So there's limited data in terms of its safety in that setting. And when you compare with Clomid, there doesn't appear to be any superiority in terms of patient symptoms, if they're hypogonadal or semen parameters. But as I mentioned, in some select populations where that testosterone to estrogen ratio is low, less than 10:1, may be useful. HCG, so this is essentially replacing LH, which stimulates the Leydig cells to produce testosterone. Dosing varies based on indication, but its primary roles are to maintaining sperm production when it's administered concurrently with testosterone therapy, although not a guarantee. You'll see us use it when a patient's been on testosterone and has some suppression, and we're trying to essentially reboot the system. And then in the treatment of hypogonadotropic hypogonadism, like Kallman syndrome that we talked about. So ejaculatory dysfunction, this is a less common cause of infertility, but if you do have ejaculatory duct obstruction, those patients are going to have low ejaculate volume and acidic pH. They can undergo a transurethral section of the ejaculatory duct. Retrograde ejaculation, again, uncommon cause, but in that setting, we can try to retrieve urine through catheterization in the bladder after alkalinization, or we can try to promote antegrade ejaculation by giving them a simplified mimetic agent and alkalinizing the urine and using that for assisted reproduction. In the setting of anejaculation, whether that's from spinal cord injury or otherwise. A couple options there are peripheral vibratory stimulation or electroejaculation. And if those are unsuccessful, then a sperm extraction is possible. But it's important to note that if a patient has an injury at T6 or above, that can result in autonomic dysreflexia. In supplements, I'll suffice it to say that this is a highly controversial area. There's no known best regimen. Antioxidants appear to be good for sperm health, but there's no standard of care, no combination that's known to be best. Cochrane review that was done showed couples undergoing ART may have live birth rates if taking vitamin E and zinc or a multivitamin. Current evidence really is inconclusive and highly debated. And just some other things in terms of patient counseling. So in terms of diet, healthy diet patterns appear to be better compared to our traditional Western diet. For patients who have occupational or environmental exposure, it's really counseling regarding, of course, avoidance if possible. That includes cessation of smoking. Certainly weight loss and regular exercise can improve fertility both hormonally and from a sperm quality perspective. We talked a little bit about advanced paternal age and the negative implications on offspring. So some of that can include neurodevelopmental disorders, musculoskeletal syndromes, retinoblastoma. And then empiric treatment, we talked about Clomid maybe being the most common. Appears to be most effective if there's endocrine abnormalities concurrent, not outside of that setting. And finally, some assisted reproductive technology information. So in general, what's pursued in this scenario is based off of what's present in a semen analysis. And there are a number of different sperm extraction techniques we can perform to retrieve sperm, whether from the epididymis or testicle. But in general, just as a hallmark in terms of sperm numbers required, so intrauterine insemination generally will say between 3 to 5 million motile sperm after that sperm is washed in the andrology lab. Traditional IVF, you may need upwards of 75,000 motile sperm. But ICSI, intracytoplasmic sperm injection, which is performed commonly today, you just need as many sperm as eggs, so that can be as low as 20 or lower in some cases. And of course, you all know about ICSI, but performed more and more routinely these days, as we talked about earlier, and really dropped the requirements in terms of sperm production needed for a man to become a biologic father. And just some assisted reproductive technology success rates for you. So you can see with timed intercourse versus intrauterine insemination, whether stimulated or not, and then IVF. So there are some scenarios where IVF success rates are much higher. Depends, of course, on the male and female factors that may or may not be involved. So in conclusion, male fertility is multifactorial. So we talked about endocrine issues, abnormal sperm production or quality issues. Of course, there can be obstructive causes. Many of these factors can be treated, whether through medical therapy or surgical therapy. Important for us to keep in mind when we're evaluating and treating these patients, they are at risk for other diseases, things like diabetes, heart disease, malignancy that we talked about. So it's really a measure of their overall health. So thank you very much for your attention, and we're happy to address any questions.
Thank you so much, Dr. Smith. That was a great lecture, really guideline-based, and you know, it's going to be so great for the trainees to go off of your slides and the discussion. Looks like Dr. Sharma here has been answering actively in the chat here. I just think because we have some time, it'd be nice to go over some of these in person, and then anything else, any additional information, we can put it on the website. And Dr. Sharma, feel free to you know, add to the discussion as well. Thank you for moderating.
Absolutely.
So I'll just do the question asking maybe, and then, you know, you two can go back and forth with the answering. Does that sound okay?
Sure.
Great.
Awesome. So there's a question here about what we categorize as dead sperm. Do they never attain motility, or is there some sort of structural trauma?
So when we talk about dead sperm, usually the assumption is if you see no motility, most people are going to say assume it was a dead sperm. With cryptospermia, which is what we're talking about, you really have to, if you were going to try to define that further, that's where that vitality testing would come into play. So I think hopefully that answers your question, but in general, to confirm, alive and dead, vitality testing, or something like or sorry, go ahead.
Sharma. So I guess to follow up on that question, it was what else can cause necrospermia? I know that necrospermia is common when it can even happen with condom use, or it's common with spermicidal use, but are there any inherent abnormalities, whether they be congenital or otherwise, that can be an underlying cause of necrospermia?
Yeah, I mean, I think you named some of the most common that you would see. So in general, when you talk about this, we're talking about patients who often have very low counts in the sperm. Some can have obstructive causes, certainly like a partial obstruction that can result in that. But in general, you're going to talk about a patient who, it has severe oligospermia, and it may be upwards of, having even just a handful of sperm. So there aren't any necessarily telltale signs, but in general, what it's going to have prompted you to do is obviously your physical exam, that endocrine evaluation, and genetic testing as well. Certainly like AZFC microdeletions, like I mentioned, some of those patients that have severely low counts will progress to no sperm, and that's just kind of the changes that happen within the testis over time.
There was a question on testis biopsy, and there are a lot of nuanced scenarios where that may be helpful, but do you have any general recommendations or guidelines as to when to consider that?
Sure. Yeah, so you'll see if you delve into some of the esoteric fertility world stuff, you'll see that our providers that will do even what's called testis mapping procedures in the office. So some have shown that instead of us going into the operating room to open the testis and do a microtesty, which is obviously invasive, that they can go through and kind of systematically map out the testis with a needle and look at different sections of it that way, and show reasonable success rates. I wouldn't say that that's really supplanted what we do in terms of microtesting, but if you're talking about just an actual testis biopsy, really don't do diagnostic testis biopsies anymore. The reason for that is that if you did identify sperm, even the presumption would be it's a patient that you might find rare sperm. You want to have the ability to cryopreserve that specimen, and so generally it's done at the time of microtesting where you're going to freeze it. One scenario where it could be done or considered is, let's say you had a patient who wants a vasectomy reversal, and that patient turns out in your interview tells you they've been on testosterone long term. And so what would happen in that scenario if you don't take them off testosterone and treat them with something else is you might go to the operating room, you look at the vasal fluid and you don't see sperm there, and you might do an epididymovasectomy. That would potentially affect their patency rate afterwards. So instead what you would do is you could re-stimulate them with something like Clomid or HCG. And then in theory, some people in that setting might do a testis biopsy to confirm return of sperm production prior to a vasectomy reversal. That's not required by any stretch. You could certainly just go straight to the vasectomy reversal. But really we're talking about pretty rare scenarios. I think importantly to know that our thinking's really changed, and that there are very few indications to do a diagnostic testicular biopsy.
Great. There were a couple of overlapping questions on kind of how genetic testing, whether it be indicated based off of the hormonal evaluation, overlaps with kind of practicality. So for example, the Y chromosome microdeletion testing, if the patient or the couple is not going to be pursuing ICSI, then what is the clinical utility of the Y chromosome microdeletions?
Yeah. So there's certainly been some debate about this. So some people, just due to the incidence in terms of when we actually detect a Y chromosome microdeletion, really goes up kind of as you get in the range of maybe 1 to 2 million sperm per milliliter. So some have argued maybe we should be dropping that threshold to begin with. Primarily the indication would be, in this setting of ART, like you mentioned, Devang, where, if the couple has a male child, that the Y chromosome will be passed on, or, obviously if you're going to go in and do that sperm extraction attempt, those are the two kind of mainstays. Outside of that setting, it's hard to argue to a couple that they have to do that. I really haven't seen that the reproductive endocrinologists or IVF folks will require it. Patients in general are going to have pretty extensive genetic screening prior to IVF at baseline, and the Y chromosome generally is a lower lower indication in terms of doing that.
And then an overlapping question was also about the CFTR testing. When you palpate an abnormality of the vas deferens, what is the role of CFTR testing, especially considering that if it comes back negative, you're still considering it as a presumptive positive?
Yeah, so in part, it's related to the fact, obviously, where if the couple is going to go through assisted reproduction, that the implications of them potentially having a child with CF, which is why you'll see it's sometimes an in-service question. The answer is to test the partner. From an overall health perspective, we talked about the indications for renal ultrasound in those patients. Notably, you can do most of the CFTR testing you'll see. It depends on your institution, but you might have some assays that test 107 mutations are most common, but you can even get whole genome sequencing. The other thing, like we talked about, is there are variations in terms of ethnicity and geography. So really, it's important for couple counseling, and particularly implicated in ART setting.
And then for the next question, can you comment a little bit on your experience or the data with TESI or micro-TESI for patients with primary testicular failure?
I mean, in general, I think almost any setting that you look at, testicular sperm extraction, micro-TESI has really shown significant advantages, both over in terms of identifying sperm, but then also in what the patient ends up with afterwards in terms of the amount of testicular tissue you're removing and any sort of implications down the road in terms of hypogonadism. The other thing to keep in mind is, depending on where you are, you may or may not have an embryologist in the operating room with you. We do here, and we're fortunate in that regard, but when you give a lab just a chunk of testicular tissue to look for sperm, in general, what's found is that they have lower chances of identifying sperm, whereas if you're giving them smaller samples and maybe there's more samples given, it's just less of, when you're looking for a needle in a haystack, if you give a bigger haystack, it's harder to find that one or two that may be there.
And this may overlap some with Dr. Krostek's talk coming up, but what is your take on hormonal optimization or stimulation for those patients prior to micro-TESI?
Yeah, so this is still debated by some practitioners, and I think it really depends on the patient population you're talking about. There are some populations where, irrespective, you have pretty reasonable retrieval rates. So, Klinefelter syndrome being one of those, even despite their testosterone exposures in some cases, or patient with an AZFC microdeletion. I think in terms of if you just have a patient who has non-obstructive azoospermia without, without an established etiology for it, if they're hypogonadal, I think the other thing that comes up is whether or not to delay to treat them and optimize. But I think a lot of the studies have really shown kind of mixed results. So it's really more provider practice based than not. I've tended to try to optimize men, just especially if you're doing a fresh retrieval. So the difference there being is that if you're doing a fresh retrieval, if you don't find sperm, then the couple's left with either using donor sperm or freezing their eggs. Whereas a fresh cycle or a frozen cycle, excuse me, is, you may try to freeze sperm. Although in this setting, usually there's so few sperm found that they may not survive a freeze and thaw. But the couple hasn't gone through a stimulation. They haven't paid, thousands upon thousands of dollars yet for the IVF portion. So there are a lot of different things that go into play there. But again, the data is really mixed in terms of if optimization helps.
All right, very good. Looks like we're at the top of the hour here. Just wanted to thank you, Dr. Smith and Dr. Sharma, for joining us this morning. Really informative discussion, and I think we actually got to a fair number of the Q&A thanks to Dr. Sharma's moderating. So whatever is remaining will get up on the website. Please fill out the survey if you're still with us here, and then we'll see you in our other Zoom room in about 10 minutes or so. So thank you again. Enjoy the rest of your day.
Thanks, Carissa. Thank you, everyone.